I am really thankful to Pakistan Chest Society for giving me this opportunity to present my research. The topic of my presentation is a chronic pulmonary aspergillosis (CPA) as a post-tuberculosis lung disorder sequelae, which acquire more attention, a clinical experience from tertiary care hospital. A short background of my study. As we all know that CPA is a destructive pulmonary disease caused by a fungal infection and a frequent complication of a treated tuberculosis. And the pulmonary TB is the major risk factor for causing the chronic pulmonary aspergillosis, not the extrapulmonary TB is that much notorious as compared to the pleural. The incidence of CPA is high in the high TB burden countries and versus it's low in a low TB burden country. So this article, the main aim of this article, the key point in differential diagnosis of pulmonary aspergillosis and tuberculosis and to promote the awareness among the clinician to differentiate among these two entities. As we all know that in TB patients there is a residual changes that can be categorized into parenchymal airways, pleural and chest wall or mediastinal pathologies, and we collectively term that pathologies as PTBLD as a post-TB lung disease, and the CPA is the most common among of them. So what we have done, we have a study design of retrospective observational study that was conducted in a Laraib hospital, and the study duration of 1 year, the data has been collected, and we have included that patient who had a previous significant history of tuberculosis, a treated case, with complaints of fever, cough and hemoptysis as the most common symptom. The relevant investigation in these patients being done in the resources which has been available in our hospital. None of the patient being sent outside the hospital. So we have examined them on the basis of clinical history, chest examination, chest imaging based on chest X-ray and HRCT, sputum examination for bacterial infection, including we have ruled out those patients who were sputum AFP and gene export were negative, and fungal KOH mount being done in these patients as well. So in the majority of our study, the cases of fungal KOH shows that there is a branching septated hive, Aspergillus being the most common organism. These patients were treated and were followed up. We have collected the data of 1 year with the evidence. We have fungal screen of KOH mount data of 1 year, which is based on actual hospital results. And HRCT findings were based on the reporting being provided to our hospital. And in these patients, post-TB patients, the aspergilloma or the fungal ball was in up to 80% of the cases. This is one of the evidence of the case which been provided. It was a female patient presented to us as she was, on the basis of the clinical history, she was a post-TB patient. Like almost 1 year back, she was treated for active pulmonary TB. She presented with an active complaints of fever, cough and hemoptysis and having fungal ball on her HRCT. Her fungal hyphae being done in the hospital limited resources, which came out to be positive, and her HRCT report is being attached as it shows that it's a post-TB sequelae with a left apical segment mycetoma. This is another case which been presented and referred to her hospital. She was post-TB as well and was diabetic with significant comorbidities. Her galactomannan and 1,3-beta-D-glucan being done some outside hospital resources, and her HRCT shows bilateral fungal mycetoma with a bird nest appearance. So the result of our study, we have total in 1 year 308 patients were presented to us, and the mean age of all patients were 43 plus minus 15 years, with majority of them male gender up to 57%. And according to our inclusion criteria, we have included those patients who was particularly negative and having a significant previous history of tuberculosis. Their fungal KOH mount being done, which came out to be positive in 172 of our cases, and 126 cases shows negative results. As the fungal hyphae has sensitivity on specificity of 44 to 60%, so we are in a doubt that we have missed this 126 negative patient. They might be positive, but their fungal hyphae came out to be negative. But they can't afford beta-glucan and galactomannan, which have sensitivity and specificity of 88 to 100%. So, based on the looking on the patient pocket and the hospital resource limited environment, we have diagnosed these cases as on our level of suspicious into CPA based on clinical and the radiological findings which be available in the hospital system. So combining with the patient chest CT imaging performance, the final diagnosis of CPA was confirmed, and these patients were traced and were followed up and were advised antifungal, and their follow-up prognosis was very good. Very little patient opt for, as they came for massive hemoptysis complaint, but rather they came very late to us, or they were never opt for surgical treatment. So the conclusion of study shows that as CPA is an underestimated post-TB sequelae and should be considered as a differential in patient with respiratory symptoms, especially in post-TB patients. The similar symptoms and chest imaging, the CPA can be misdiagnosed as a smear negative case, and their specific differential diagnosis is based upon the serological and the microbiological criteria, which has been introduced by European Respiratory Thoracic Society. उनकी अपनी गाइडलाइन आई थी जिसमें उन्होंने कहा था कि सीरोलॉजिकल और माइकोलॉजिकल क्राइटेरियाज को इन्वॉल्व करना चाहिए, लेकिन चूंकि हमारे पेशेंट जो है वो स्पर्चुलस आईजीजी को नहीं अफोर्ड कर सकते आउटसाइड, या गैलेक्टोमनान को नहीं अफोर्ड कर सकते, या बीटा ग्लूकेन को नहीं अफोर्ड कर सकते, तो हमने फंगल हाइफी को अपने ही हॉस्पिटल के डेटा पे एक्चुअल पेशेंट बेस्ड अपॉन द क्लिनिकल एंड द स्पर्जिनोमा फाइंडिंग और HRCT जो है उनको डायग्नोस किया और उनको एंटीफंगल एडवाइस. Now, some future recommendation and some further research, for the further research, as we all know that the Spurginus specific IgG is the key point in differentiating this tuberculosis reoccurrence with the sensitivity and specificity of 84 to 89%. And various methods being further introduced, including the fungal culture, galactomannan testing, 1,3-beta-D-glucane testing, and PCRs as well. There is another thing which is being done in the foreign countries but not introduced in Pakistan till yet. It is BAL metagenomic next generation sequencing testing, which is also beneficial in improving the diagnosis of CPA with a high sensitivity and specificity. So it can be a further research recommendation as well. In a selected group of patients, the CPA weekly subcutaneous interferon gamma is proven to improve the disease control and further frequency, reduce the frequency of exacerbation and hospitalization. This point is based upon many of the meta-analysis and systemic review, but haven't been practiced in our study. So there is some limitations in our study. As the human galactomannan was done from outside hospital source according to the affordability of the 20 patients among these 308 patients, and among of these 16 came out to be positive and 4 were negative. We have, as per guidelines, have to screen all of them, but as it's not available in our hospital, we have to send the patient outside the hospital, and it's expensive as well. And the HIV screening, which is the most common one, as we have to keep in mind the immunocompromised status of the patient. So HIV screening being done in almost 50% of these 308 patient enrolled studies, and all turned out to be negative. Some take-home message, as we all know that many patients with CPA live in a low and middle income countries, and they develop chronic pulmonary aspergillosis following the post-TB. Not all recommendations of ERS guidelines can be implemented in the low and the middle income countries as like in Pakistan. So we are lagging behind, and we have to do our researches according to the capacity which is available to us. I am really acknowledgement to the Department of Liquid Hospital for providing me the data. Here are some references of my research, and thank you all.